The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. Welcome. We've got about 1 minute to 10, and so we're actually going to wait until about 10:02 when we get a bunch of people signed in already. So please, we thank you for your patience. Hi, everyone. It's 10:01. Please get comfortable. We're going to begin in 1 minute. Good morning, everyone, and welcome. It's August already. Can't believe it. This is Ruth Cologne Wagner, Director of Training and Development with NIAPers, and welcome today to Outcomes Aren't Just for the Boss Anymore, how to incorporate outcomes into our work. I'm very happy today to have Laura Langner join us. She's the CEO of Complete Compliance Solutions, and her presentation is brought to you today by the New York Care Coordination Program, or NYCCP. And I just wanted to let you know, remind you that we are actually in the home stretch. This is activity number 11. We started in January. We had wonderful videos and excellent webinars. And so this is the 11th one, and we've got the whole thing is 14. So 3 to go, and we're just so happy you've been with us along the way. So we are definitely in the home stretch. If you could go on to the next slide, please. So Laura is brought to you, as we indicated, by NYCCP, and they are one of our partners. And we're just so, NIAPers is so very proud to be working with our partners, and they are the New York State Council for Community Behavioral Health, the New York Care Coordination Program that brings you today's webinar, the Center for Practice Innovations, the Coalition of Behavioral Health, as well as the National Council. And the National Council will be bringing us our next webinar in September. So for everyone who was on our last webinar, it was called Culture, People, and Me. It was fantastic. It was well attended, and it really received great reviews despite our technical difficulties. So we really just want to bring this to you, to everyone who hasn't seen it yet. And without those technical difficulties, and NYCCP has graciously said that they will re-record that. And so as soon as that is done, probably in early September, we'll be able to get that to you and post that on our website. So we're very excited to bring that to you as well. Attendance, as we always indicate, I know many of you are watching in groups, so please just make sure to email us and give us the names of everyone who was there. You're going to be receiving an email immediately following today's webinar for the evaluation. So please, if you're watching a group, the person that receives that, forward that to the rest of the team. For all the missed trainings, if you have any missed trainings, please go to our website where you'll be able to watch the video as well as download the PowerPoint presentation. You probably already know and have received several emails from Cindy Levinoy, and she's of NYSCCBH, and she is reaching out to everyone. She's doing the outreach to remind you to watch anything that you've missed. And she would also let you know what you've missed or what evaluations are missing and so on. And then today's CEUs, we are offering licensed mental health counseling for today, social work, CPRP, and CRCC. If you have any questions in general, we'd like for you to please visit our website. There is a frequently asked questions section. If that doesn't answer your questions, then just feel free to email me directly. So before I introduce Laura, I just want to remind you that we're going to have a question and answer period at the end. And on my screen, it's on the right side, but your panel, which is probably on the right side, there's a question box. And so I'd like for you to please use that question box to ask us questions, and we'll be reading that at the end of the presentation, and Laura will be responding to your questions. But we also just want to emphasize that as you think of your questions throughout the presentation, feel free to put them in there. I will be receiving those, and I will just hold those to the end. All right, so here's Laura. She is the CEO of Complete Compliance Solutions, and that is, as she has here, a national company, and they're dedicated to supporting organizations that service those that are vulnerable. She's worked in the not-for-profit field for 30 years in a variety of settings. Her experiences are varied, and they include clinical service delivery, grant writing, training, education, and monitoring full compliance from different levels of organizations. So with that, it is my complete pleasure to bring to you Laura as part of our Peer Management Training Initiative.
Good morning, everybody, and thank you, Ruth. So the first thing I want to do today is I want to go ahead and go over the learning objectives that we're going to focus on. Understanding outcomes as a part of your service delivery. Defining triple aim outcomes. Learning to identify social behaviors and social determinants of health, for example, individual, social, or community factors that may influence an individual's ability to reduce the emergency room visits, avoidable hospital admissions, or their ability to actually utilize their primary care. And last, I want to talk to you about the relationship between those healthy behaviors and health outcomes. So one of the problems that's encountered when we use the term outcomes is that it means different things to different people. So some people use it to represent standardized patient-reported outcomes. The problem is that what the patient tells us isn't typically recorded, and it's never compared with other patients in order to identify patterns and trends. We also use the word outcomes to talk about patient satisfaction measures. Well, typically this is done as part of a mandate. It has to be submitted. But do we compare it year to year? Do we look at the patient satisfaction across providers? And then lastly, outcomes sometimes have no foundation in which they're based. They're not evidence-based. They use questionnaires that haven't been validated. So randomly picking different measures or outcomes that have no basis in the work that we do. So we want to go beyond just demonstrating value. A seamless integration with evidence-based outcomes has a number of other benefits besides saying this is a valuable service. It can help with quality improvement. It allows the agency you work for to market its success and demonstrate to the people, the consumers looking and trying to decide where they're going to get services, who's the best provider for them. It prepares you for value-based care. It helps in negotiating contracts with managed care to be able to say, we do this and we do it well, and we have something to document that. And most importantly, in my mind, it helps with process improvement. So what is quality improvement? The routine use of reported outcomes allows us to evaluate staff job performance and to target continuing education aimed at opportunities to create improvement. It also allows us to identify patterns and trends in our population early enough to actually respond to something before it becomes a crisis. So then what is process improvement? Well, it's going to sound relatively familiar. It's going to actually sound like utilization reviews. Outcomes help us ask ourselves some hard questions so that we can optimize the services that we provide. Is there a need for a lower or higher level of care? How much of a particular service is enough? Should we see someone weekly? Do we need to meet with them monthly? Do we need to make sure that we engage this individual on a more frequent basis than what is traditionally done? Are there barriers impeding the individual's ability to make progress? Do we address them, or do we just simply record them and say, well, this was the barrier that stopped us from meeting that objective or goal. However, we have to make sure that we're always addressing the barriers. If you think of this as a utilization review, it's done on the individual level. But for outcomes, we can even apply that as a practice to the practice as a whole. So if we're starting to look at how many people need higher or lower levels of care, what do they have in common? What are the things that are driving the individual to overcome barriers? Can that be applied to other individuals that we work with? Moving forward. So this is where we're talking about value-based payment. The change coming in the next 2 to 5 years requires a shift of focus and an optimization of the business processes so that the patient-reported outcomes become routine and seamless part of the work. Focusing and documenting outcomes needs to become as routine, as ordinary as logging into your computer in the morning. Well, all of that is fine and dandy, but how do you track outcomes? A lot of people that I meet in the field will say to me, well, that's not my job. That's the job of the manager or the company I work for. It's not really something I do at the direct service level. But that's not true. The data comes from the direct service level. And yes, it can certainly be used at an organizational level, but it helps you, the individual provider, to be able to track your own outcomes. So how do you do this? Well, don't ignore the systems you already have in place. You have an electronic health record. That electronic health record will allow you to capture outcomes. So all or most of you use some system, and they are designed to capture outcomes such as medication adherence, hospitalizations, housing. But let me be really clear. Goals and objectives are not outcomes. Outcomes are the result of meeting a goal or objective. Goals and objectives are incremental steps that are met that lead you to the outcome. Each of you should be able to run reports in your electronic health record and be able to derive where it is you are in helping the individuals you work with meet outcomes, not just goals and objectives. So one of the things that sometimes can be problematic is that we have the patient or the individual that you're working with, and we want to start following up on outcomes. But in order to tell if someone's improved, you have to have a baseline. This means that the conversation needs to really start at intake. this is going to require you to do more than simply check boxes, write narratives on intake forms. It means that you have to create a baseline. You need to know the frequency of prior episodes, such as relapse, medication, non-adherence, and resulted hospitalizations because of medication non-adherence. In order to demonstrate change, you need to have a starting line. It's therefore important that you make sure you collect quantitative data at intake. Not simply say, have you ever relapsed in the past? How many times have you relapsed? What were the dates of those relapses? Have they been in the last 12 months? What were the reasons for that? This will allow you to then establish outcomes and compare what it is, the frequency, or what it is that's the barrier, or how often they're having relapse, for example, in the 12 months they've worked with you as compared to the 12 months they haven't worked with you, or 3 months they've worked with you. So if we understand that outcomes should be a part of your everyday job, and that you have systems in place to be able to collect that information, and you recognize that at the very beginning of your interaction with the individual at intake, you need to be capturing quantitative data that actually will inform the outcomes you want to track. The question then is, so what outcomes should you focus on? So we're going to talk today about triple aim outcomes. People with complex health needs face challenges, such as chronic health conditions, behavioral health issues, they have trauma history, food insecurity, or homelessness. When high-need patients require medical services, they often encounter a healthcare system that is poorly coordinated, inefficient, or expensive. All too often, they experience poor outcomes due to avoidable emergency department visits and hospital stays that don't improve their health. Meeting the needs of these patients is considered an economic necessity. So the triple aim framework serves as a foundation for organizations and communities to successfully navigate and transition the healthcare system to optimizing health for individuals and populations. There are 3 outcomes that the government has decided to focus on in order to improve the healthcare system. Improving the health of the population, enhancing the experience and outcomes of the patient, and reducing the per capita cost of care for the benefit of the community. So consider the following example. An organization might initially cut costs by decreasing the length of stay. But this improvement isn't meaningful without considering how decreasing the length of stay affects the actual outcomes and the patient experience. Did the quick discharge increase the incidence of readmission, risking the patient's safety and eventually increasing costs? Did it increase or decrease the patient satisfaction? Achieving the appropriate balance among the 3 dimensions in triple aim outcomes is fundamental and critical to achieving a long-term change in the healthcare delivery system. So each state looked at the triple aim outcomes that the federal government identified and formulated their own triple aim outcomes that the state would focus and use as benchmarks to measure whether or not an organization or an entity was being successful. In New York State, the pathway to triple aim has been identified as reduced emergency room visits, reduced preventable hospital admissions, and increased primary care. So let's focus for a minute on the word preventable. When we're talking about reduced hospital admissions, we're not talking about someone comes in with a broken leg and we tell them, really, don't go to the ER. Let's go ahead and go to the local clinic and let's go see if it can get fixed there. If someone is in crisis and needs to go to the hospital, we're not talking about not going to the hospital. We're talking about preventable incidences. So for example, if we talk about someone who has a chronic illness such as diabetes, can we help that individual learn to manage their sugar in order to prevent hospitalizations because it's out of control? So within the healthcare delivery system, you as individuals who work in that system play an essential role in achieving the outcomes through effective care management and care coordination. But identifying benchmarks to meet the triple aim outcomes does not tell us how your client is going to actually achieve that. So let's look at each of the triple aim outcomes one by one. Better care. When looking at better care, it's reasonable to assume that this has the greatest impact on the other two outcomes. This is where you can make sure that the individual is able to work towards achieving their triple aim outcomes. I want to quote Rita Mae Brown for a minute. Insanity is doing the same thing over and over again, but expecting a different result. If we continue to hit a wall and we just constantly keep pushing against the wall in the same way that we have done it in the past, we can't expect a different outcome. So for many of our individuals that we work with, they've had certain health problems for a long time, or they've had housing issues, or they've had domestic violence issues, or they've had other things in their life that they've had over a period of time. And they have consistently approached them using the same type of approach without actually looking, stopping, and saying, what is the barrier? How do I address the barrier? Is there a different way that I can approach this so that I can possibly have a different outcome? Do you need a different provider? Do you have to change the way in which you get to the provider? Do you need to make sure that you have a better understanding of how to advocate for yourself prior to going to a provider? If you're not good at tracking or remembering to take medication and you're classified as being medication non-adherent, simply telling the individual over and over that it's really important that they take their medication as prescribed isn't going to change the outcome. However, developing a system with them, using alarms on the phone, getting pill boxes, pill trays, things like that, can change a person's ability to be medication adherent because we have approached it using different methods. So what's your role? Well, as a healthcare management staff person, you contribute to a client's ability to achieve improved health outcomes through comprehensive care management, care coordination and health promotion, comprehensive transitional care, and increased utilization of peers, family, and natural support. But to be effective in any of these, you need to understand what impacts an individual's decision-making process. We go back to, are you throwing the same thing as everybody else at the problem and there's no real change? You need to learn and understand why the client makes the decisions they make. What is it that they want? What is it that they need? And why do they believe they want and need that? So, what behaviors and social determinants impact triple aim outcomes? So often, staff focus on the triple aim outcome instead of the behavior or the intervention that really impacts the outcome. So, reduced ER visits. And what we focus on is redirecting the client somewhere else other than the ER department, instead of focusing on why do we always go to the ER department. It's the difference between treating a symptom of the disease or the cause of the disease. So you'll notice the person in the upper left corner. That's about as much exercise as I do. But we want to talk about healthy behaviors such as exercise. So health behaviors, sometimes called health-related behaviors, are actions taken by the person in order to maintain, attain, or regain good health. It prevents illness or death. They can be intentional, they can be unintentional. They include things like smoking, diet, substance use, and my little friend in the left corner, physical activity. Actions that can be classified as health behaviors are many. Examples include the ones that we just listed, but also include sleep, risky sexual behaviors, healthcare seeking behaviors, adherence to prescribed medication treatments. Health behaviors are frequently discussed as individual behaviors. But the truth is, they can be measured and summarized for individuals, groups, or whole populations. Health behaviors are dynamic. They're varying over the lifespan of an individual, across cohorts, across settings, and across time. Most of your clients are Medicaid beneficiaries with one of the following conditions: living with HIV/AIDS or significant mental illness, living with 2 or more chronic conditions such as asthma, diabetes, heart disease, mental health condition, or substance use disorder. This makes them a group that has similar behaviors. So let's talk about smoking, for example. With smoking in the United States, the likelihood of starting starts based on age. Recent groups of adults are less likely to smoke than those from the mid-1900s. Smoking is higher in the southern part of the United States than in the West. Smoking became less common after 1964 because that's when the Surgeon General's report was put on a pack of cigarettes. Prior to that, we actually had doctors prescribing smoking to women that were pregnant and had morning sickness. Tobacco use is also more common in populations of poverty or high health populations, such as the ones you serve. So then we have to look at what's called social determinants, as we talked about in the smoking. What impacted the individual socially that helped them decide their health choices? So a holistic approach to disease and prevention, health promotion, recovery and wellness are all part of social determinants. This approach seeks to understand, how does the social world shape an individual's health? Do I do something because my community does something? Do I start smoking or drinking or experimenting with illegal substances because my peer group is doing that? Is something socially acceptable within my cultural group? How a range of personal, social, economic, and environmental factors influence individual and population health status and outcomes. So another example is the Affordable Care Act, which changed rapidly the way people looked at health care in the United States. You will learn about social determinants of health as you learn some of the skills we'll teach a little later on in this presentation. So people make decisions based on beliefs, attitudes, values. Why is something important to me but not important to you? Our interactions with others and life experiences shape our thoughts and actions. So I want to tell you a little story. When I was in college, I had the nutty professor. He was the dean of the social work department, and he would often babble. And one day he came into the classroom and he had 3 students with him. One student carried a metal pail filled with hot water, steaming. Another one carried a metal pail filled with cold water that had ice in it. and another one carried a metal pail with room temperature water. He had two students get up. One put their hand in the hot water, another put their hand in the cold water, and he started teaching. About 5 minutes pass, he has the two of them take their hands out and place it in the bucket with the room temperature water, and he hands them a card. And on one side of the card it says hot, and on the other side of the card it says cold. And he looks at the person who had their hand in the hot water and he says, "What temperature is that water your hand is in now?" "Well, I came from hot water, so this feels cold." And he looks at the other person and she says, "Well, I came from cold water, this feels hot." And the idea, the lesson was that each person's truth, each person's perception is based on where they came from. So throughout the course of your life, you are filling your bucket with experiences, with interactions, with lessons observed and learned through our family, through our friends, through our peers, through our teachers, through our jobs, through our employers. And every time we encounter another situation, our brain goes to that bucket to say, okay, where does this fit and what is my frame of reference? So when we look at lifestyles, we are looking at an individual's actions and behaviors that have made up their daily activities. These can include their job, their profession, their occupation, leisure activities. Do you go canoeing? Do you go hiking? Do you play dominoes? Do you play cards? What's your diet? Is your diet based on your culture? Is your diet based on the resources available to you? Are you aware of other diets? What are your social interactions with your family, your friends, your neighbors, your peers, your employees? Health lifestyles are enacted at the individual level, but they're shaped by the global level and the familial level and the community level. Understanding the interplay between someone's health choices and their health behaviors is seen as fundamental for changing them. If you don't understand that the reason Laura smokes is because Laura's fondest memories with her father were when he would go outside on the porch and smoke, and that was when he would talk to her or play cards with her or whatever else, and that for her, even unconsciously, smoking relates to a positive experience, simply telling Laura smoking doesn't work, is bad for you, isn't going to change that. You have to understand why we choose to smoke, why we choose not to go to the primary care, but instead wait for the emergency room. If you can figure out the why, if you can figure out what's in the bucket, then you can affect long-term change with your clients, and they will have an aha moment. And if you can do that, now we're looking at being able to achieve outcomes. So one of the things that you have to understand is that in this social network, when I went to social work school, we used to use a term called PI. It was person in environment, and it speaks to these social determinants of health. This used to be a pie chart, I'm very old, that we used when I went to social work school. And what it did was it said the outer ring was the community. The next was the family, and the internal ring was the individual themselves. Along the outside of the circle, you would write the areas that you wanted to work on with the individual. So safety, learning and development, material well-being, relationships, it could be mental health and substance use, it could be physical health, and you create a pie wedge for each of those areas. And then what you do is you talk to the individual you're working with and you ask, what on the community level is impacting your physical health decision making? Maybe there's no health services within a reasonable area. Maybe the only health services that are available for your particular substance use disorder, mental illness, you don't want to go to them within your own community. You want to go outside of your community. Maybe within your family, the healthy eating choice is, I'm not the one that cooks, I'm not the one that shops, I have no control over that. My spouse, my partner, my parent, my roommate is not going to change the way they cook simply because it's not good for me, I don't know how to make better health choices when I don't have control of that. On the individual level, it may simply be, look, the only time I'm happy is when I am eating. That sugar, that cake, that candy gives me personal satisfaction that I don't have anywhere else in my life. And so you create one of these pie charts utilizing all the different pie wedges, and then you start to look for patterns where you can address a particular barrier or a particular social determinant that's impacting multiple issues. And it allows you to help the individual feel successful sooner. So one of the things we have to remember is that we go ahead and we make decisions not just based on what's happening in the moment, but what's been put in our bucket from the very beginning across our life course. Health behaviors change over an individual's life. Some behaviors, like riding in a car seat, are only important early in life, while others, like drinking alcohol, may emerge later in life. Yet people with similar social locations exhibit similar social behaviors. So if you think about it for a second, my children were allowed to come home from the hospital in a car seat. That was relatively new, but we didn't have to bring the car seat into the hospital. We just said, yes, we have a car seat. We would take the child out and put them in the car seat. My daughter's child isn't even allowed to leave the hospital room unless they're already buckled up in a car seat. And when my parents brought me home, they had a box that they sat on the back seat, and it was like roller derby in there for the baby. Things change over the life course of an individual's life in the way society perceives it, what is socially acceptable, and it helps you understand why people make the choices they make. So life course theory approaches health as an integrated continuum rather than disconnected stages. So what happened to us in our childhood impacts our decisions as an adult. How many times have we had a senior say to us, well, that's not the way we did it when I was younger, and the right way to do it is this way? Because their frame of reference, their bucket, shows them that this is the right way, and that's why they're making their health decisions. What happens to us early in our lives can have significant impact on the quality of our life and the well-being of our future. It's important to help clients have positive, healthy experiences, to have adequate supports in place and ample opportunities to learn and to make mistakes so that they can have better outcomes later in life. Our clients need to understand that making a mistake isn't necessarily negative, that often making a mistake has the most impact in positive, healthy choices because it gives us an opportunity to learn and make corrections. So where do you fit in? Well, that's a good question. The truth is that you impact a client's health outcomes in two areas, in the plan of care development and in engagement. So in establishing the goals, which leads to the outcome, which then defines the intervention, objective, which then defines the intervention, which leads to the outcome. That plan of care then gives you a framework in which to work on the steps needed, goals, objectives, and interventions, in order to reach the outcome. But none of that matters if you can't engage the client. So I want to talk to you about a couple of techniques that work. So I know that in January, you had another training called Unlock the Secret to Successful Engagement. And in that, you talked about active listening. You also had a training on motivational interviewing in March, and there was a video there called Did You Hear That?, which was also on motivational interviewing or active interviewing, active listening. I'm not going to spend a lot of time, but I do want to remind you to go back to those two presentations if you want more information. Active listening contains 7 steps. Active listening is not the ability to repeat word for word what someone has said. Active listening is about hearing instead of listening to someone and what they're saying and looking at their facial expressions, their body language, asking questions, and being able to determine the value that someone places on what they're saying. So, for example, research shows that if you ask someone to list their symptoms, that they will automatically list them in the order of importance. So it's important to know that when someone starts to give you a list of things, that typically the first 2 things they say are the most impactful and most important to them. When you're using your active listening skills, you need to remember to be attentive. That doesn't mean to stare deeply into their eyes without blinking. You have to ask open-ended questions, which means they can't be answered with a yes or a no. Not, do you feel good today? But how do you feel? You have to ask probing questions. You need to request clarification. Do not assume you know what they mean. You need to paraphrase it, state it back in your own words. You need to be attuned to their feelings and the way their body language and their facial expressions, their tone of voice, their use of silence and pausing tells you what's important, what's impactful, what's hurtful, what is a barrier. Then you need to summarize and make sure you have it right. Another skill that's unbelievably important in being able to help people understand their social determinants of health in order to be able to get to what is in their bucket so that you can get to the outcomes is collaborative documentation. And I know a lot of people have heard about collaborative documentation on and on, right? But we want to make sure that everyone understands that collaborative documentation is really about empowering the client. It allows them to be in control. Within the context of health home care management, as it relates to using the information, plans of care, service provider notes, updates, achieving quality plans of care happens when you do collaborative documentation. So why do it? Well, it improves the client engagement and involvement. It supports person-centered practices. It increases the capacity of real-time communication with other providers. It helps focus the work on outcomes. So why change something if it's been working for so long? Well, the truth is, has it really been working? How many individuals have been with the same providers, doing the same thing, addressing the same goals without demonstrating progress? So the golden thread, the thing that ties everything together, occurs when you do collaborative documentation. Because in collaborative documentation, it allows the client throughout the course of interactions with you as providers to be able to see how everything connects together. So think of quilting for a minute. In quilting, you take very small pieces of fabric, completely different. They can be different colors, different patterns, different textures, and individually, they're often useless. They're too small to be used for anything. But when you piece them together, when you tie them and sew them into something larger, you then get to see the bigger picture. So developing a meaningful narrative that follows the golden thread. So collaborative documentation is then able to support a meaningful conversation. It validates the client's thoughts. Medical necessity, which means demonstrating progress while working towards goals, and compliance all occur. You even achieve efficacy because you're able to go ahead and accomplish multiple things at once. Tying your intake to your assessments, to your plan of care, to the providers, to the treatment, to all of that. If the client can see how all those things connect, They then understand the value it brings. And that is best achieved with collaborative documentation. So how do you do it? Well, you have to introduce it to your client. You should use it with the plan of care, and that means it's not automatically filled out but when you start. You have to introduce the goal and objective to be addressed. You have to ask the client or the note taker permission to take notes. You render the service, and then you invite the client with you to go ahead and document whatever it is you're going to put in your electronic health record. Another technique that's very helpful is called reframing your message. So when you go to reframe a message and promote health and positive behavior change, you need to understand that there's a close interdependency between a person's mindset, their idea, their preconceived notions, and their behavior. Each reflects an important component of the change process. Yet many practitioners are better prepared to address a behavioral dynamic than the actual implication of the dynamic. Although successful change facilitators attend to both when attempting to redirect a person to an outcome, what happens is we sometimes get confused about how to say the message in a way that it can be heard. So we have to learn to reframe it or frame it for reference. Each individual has a unique way of interpreting the world. If I see an object, it means something to me based on what's in my bucket. Some people are very offended by different terms or language or particular words. Other people are not. How do you know when to use it and when not to use it? We need to look at the individual's professional background, past experiences, education, and that all influences an individual's viewpoint. So if you go back to that pie, that circle, that will help you determine a person's priorities. For a person's frame of reference guides their attention, their goals, their actions in any given circumstance. Should I eat lunch or should I exercise? Should I return a phone call or send an email? Should I take the time to interact now or put it off till later? Is it someone that procrastinates or is it someone that addresses everything head on? Make sure that you look at their culture, you look at all of the things that show up in this person and environment and allow you to see what it is that's impacting the person's healthy decision choices. You have to frame it for them so that they can reference it in their bucket. So often what happens is we do one-step communication. I talk, the receiver listens. But then we don't know if the receiver actually heard what we had to say. Instead, what we want to do is we want to allow the individual to let the receiver or the client talk first, to be able to help us understand what's in their bucket, what is their frame of reference, what are those things impacting them. Once we understand that, then we can reframe the message so that the individual can hear it, not just listen to it. When that happens, then the individual is able to take that message and add it to their bucket in a way that it changes decisions that they make going forward. So they have a higher likelihood of acceptance. So what is your job? Your job is actually to circumvent the obstacles. The work has to be done by the client. If you're the individual doing all the work, then there's no sustainable change because the moment you leave, the individual no longer has the ability to sustain it or to continue it. You have to help individuals get around roadblocks. It's one of the most important things that you will do. Even if he or she does a terrific job of communicating their ideas and motivating clients to work towards realizing them, the client is still going to encounter obstacles. That's part of life. You have to be able to help the individual understand, first, that obstacles are part of life, two, that they can overcome them, go around them, or address them, or choose to move and rethink their goals. You are the one that's going to help fix the disconnects. Effective care management staff see people where they are and help them come together and be able to identify the barrier, identify the ways to address the barrier, or identify that the barrier isn't movable. And they have to understand, is it okay that I am where I am, or do I want to create a different goal in order to get to the outcome? Utilization of peer, families, friends, community resources all play an important role. So let's talk a minute about one more skill. We have a few minutes left. Agenda mapping. Agenda mapping is a process of seeking and maintaining direction. If you don't know where you're going, then any road will get you there. So why might agendas be helpful? Because for clients that have so many things they have to address at once, or for individuals that have difficulty focusing or being able to understand what has to be done first or second, agenda mapping is a concrete, tactile way to get to that point, that they have a map or a set of instructions that they can follow. So content, contributions, what it is the person wants to work from. Agenda mapping, you will get the handout later, has 3 columns. In the first column, you're putting all of the goals, all of the areas that the person wants to work on. Think of the outside of that pie chart. You may have mental health, you may have substance use, you may have housing, you may have food, you may have transportation, whatever the issues are. It assists the client in prioritizing, because once you list each of the areas you want to address, you then move to the second column to the right, and you start to talk about, well, what are the steps that you need to accomplish in order to get that goal attained? And when you move to the right, you assign the steps to the client, to another provider, or to be done with you. At no point should the steps be only yours. At every point, the client needs to be engaged and needs to have the ownership of it. Once you have the steps listed, you can then go ahead and see where you can get some economies of scale. Is there one thing that you can do that will accomplish 3 goals? You then move to the last column, which is listing the steps in order of priority. A client's agenda can include hopes, fears, expectations, concerns. This is done through a process of focusing, using particular tasks and skills to harness an agenda. The agenda mapping is led by the client and guided by you. Your job is not to be the decision maker, but to assist the client in seeing all the options and the consequences of their choices. So for example, here are all different areas that you can use when developing your agenda map. It requires you to help the consumer identify anything they feel is impactful in making better choices. So I want to go back to a slide for a second. So agendas allow you to create a structure when someone has complex work or so many things that they're working on that they think they have to tackle one by one, and they can't see where there are overlapping tasks. It's mutually created. It's created and modeled after the spirit of motivational interviewing. The engagement is essential to make the progress towards the goals. And our ability to focus and guide the interactions helps the client reach the goals, which in the end then allows the individual to attain outcomes. So what are today's takeaways? Behaviors and social determinants influence an individual's ability to achieve the triple aim outcomes: reduced ER visits, reduced hospital admissions, and increased primary care. You are the golden thread that supports the client in improving their health, their wellness, their quality of life, in enhancing the client's experience, the level of engagement, and again, the quality of their life. Using effective strategies and best practices throughout health home care management process will aid you in maximizing your impact through the improved health and lower cost of care, your outcomes. Questions?
Okay, my gosh, thank you so much, Laura. Really appreciate that. Right now I'm looking at the question box. We've got one that came in and that was answered, excuse me. And we're looking for some more. So people, please feel free to begin now to enter your questions into the question box. And Laura, who shared so much with us already, that she can give you greater detail. As we're waiting for that, Laura, I just wanted to say that I thank you for bringing the outcomes to life, and I really appreciated, in particular, the perceptions based on their previous experiences, and that just really hit home for me. And it's things that we intuitively know and would bring to our work, but I've never heard it explained the way you did it, and I really did appreciate that.
Thank you. I think one of, as individuals, we all know sometimes we do something because that's the way our parent did it, or that's the way someone significant, a teacher or someone, a coach, somebody significant in our life impacted us, and it really left a mark on us. And so we think that way and we bring it with us. What we don't realize is all the unconscious things that do that for us. That bucket exercise that my professor did in college has stayed with me for decades, because I always thought truth was truth. It was either right or wrong. It either was truthful or wasn't truthful. But the reality is that every person's perception or their truth is based on their entire life's experiences and interactions. And if we can get to that, it helps us understand. So I used to work in domestic violence, and so often I got the question, well, why doesn't someone just leave? Why would they seek out that behavior? But if you look at the research around domestic violence, it clearly shows that it's cyclical, that young girls who grew up in houses with domestic violence unconsciously seek out abusers. And young men that grow up in houses with domestic violence unconsciously mirror those behaviors when they get older without significant intervention. And I think it just speaks to the fact that we can't simply just say to people, well, don't do that. We have to understand why they're making the choices, and that the outcomes are so ingrained in what it is that we do on a day-to-day basis, and that we just don't realize it. And we have to be paying attention to those things and utilizing the tools that already exist in our electronic health record system.
You know what? There are no questions coming in, and so I'd just like for you to take the next 2 minutes that we have left and maybe go back in a bit into agenda mapping and the information that you're going to give us, the actual agenda mapping that you're going to share with the audience.
So the agenda mapping is a worksheet, and you will get that has 3 columns. The sheet is horizontal. It goes from left to right. And in the first column, and agenda mapping actually comes from the DD world, the developmentally disabled world, and it's used quite often with individuals who have some cognitive impairment or have some inability, ADHD, ADD, or have an inability to organize thoughts. And it's a wonderful, wonderful tool. It allows you to take the individual's large picture, think of all the goals or the outcomes that you want to meet, whichever one you want to address, and put them on the left side of the paper, and then have the client, by focusing on one at a time, articulate what are the tasks. So if, for example, I have a anger management problem, and I also have a housing problem. I currently live in a shelter. I lost my housing. You may find, as you identify the task to deal with my anger, I may need to identify a provider, a mental health provider. I may need to discuss getting on medication. I may need to develop coping mechanisms. I don't have transportation to the provider, so I have to find transportation. You may then find with housing that my anger has caused me to lose my housing in the past. You may find that the housing, I wasn't able to maintain a job because of my anger and therefore lost my housing in the past. And so what happens is you start to identify each and every barrier, concern, task, fear in the second column. And when the second column's done, you then try to identify where things overlap. So that maybe housing feels super important and you can work on that, but you have to work on the anger management, because if I don't, even if I get housing, I'll lose it again. I won't be able to keep the job.
Yeah, so I really appreciate you explaining the mapping. We do have a couple of questions that came in. It is 11 o'clock, and I do just want to say, if you want to stick around, Laura, and if you'd be so gracious enough, if we could take the next 2-3 minutes to answer some of these questions. Okay, so let me, can you use the mapping on a person who's autistic?
Yes.
And see how fast
it actually comes from the DD world, and autism spectrum is in that world. The mapping may require you, when using it with someone on the autism spectrum, to be able to do less at a time. You may have to break the mapping up into multiple sessions. But yes, it absolutely is a tool specifically for that population.
All right. So, Louisa, I just want to answer your question. We're going to be providing you this tool as soon as we upload the recording of today's video, which will be in a couple of days. We will also add that tool to our website. And we will also be adding today's PowerPoint to that. I do have another question. What is the best way to incorporate evidence-based health measures, for example, smoking cessation, with patient-centered goals that do not include smoking cessation?
So I think wellness, when you talk about patient-centered goals, you want to make sure smoking cessation may be an objective of a larger goal, and the goal may be a better quality of life. The goal may be related to wellness. The goal can be related to, it can even be related to things like housing. It's easier to get housing if you don't smoke, particularly if you're going into some government housing. If you're talking about interpersonal relationships, the smoking may impact that. You may want to start actually with that pie chart that I had, put smoking on the outside and talk about the community, the familial, and the personal barriers that smoking creates, and then see if you can identify a larger goal or even an outcome based on where smoking isn't the goal, but smoking is the barrier to meeting the goal.
Thank you so much. And I'm going to just point out to Catherine that I haven't forgotten your comment here. I do have it. What I'm going to ask Catherine for you to do is just email me what your question is in respect to your comment, and then I will forward that to Laura and we'll return the answer to you. So everyone, thank you so much for joining us today. Laura, thank you so much. It's always a pleasure to work with you. And we will see everyone next month. So we have your critical role in care transitions, and that's being brought to you by the National Council. And the date for that, please excuse me, is Thursday, September 20th at 10 a.m. Everyone, thank you so much and have a wonderful day. Thank you, Laura.
Thank you. Have a great day.
Bye, everyone.